Bismillahirrahmanirrahim. Assalamualaikum dear students. I am Professor Dr. Talat Najib, currently working as Head of Department ENT at Fazaiya Medical College, NPF Hospital, Islamabad. I have more than 20 years of teaching experience, and today I am going to start the series of lecture regarding important topics of ENT, because I think that it is very difficult for undergrad medical students to extract the required knowledge to clear their concepts and to get through the exam. So these lectures are very easy, concise, and have all the knowledge that is required to get through the exam. Hopefully you will like these lectures, so give your feedback, comments, and like the video and subscribe the channel so that you can watch more videos. Bismillahirrahmanirrahim. So first lecture in this series is related to diseases of oropharynx. So first of all we will discuss diseases of tonsils. So you can see in this picture patient is presenting with pain in throat, that is rhinophagia, and in this picture you can see hypertrophic, enlarged, congested tonsils with yellow spots over the tonsils. That is the picture of acute follicular tonsillitis. So by the end of this lecture you should be able to solve this scenario. We will discuss this scenario in the end of this lecture. So first of all, what are the tonsils? Tonsils are the lymphoid structures. They are present in the tonsillar fossa, that is on each side of oropharynx, in the lateral wall of oropharynx. So these tonsils are called palatine tonsils. Tonsillar fossa develop from the dorsal wing of first pharyngeal pouch and the ventral wing of second pharyngeal pouch, and all this process will place in the 8th week of fetal life. So this is the anatomy and embryology of the tonsillar fossa. So this fossa is bounded by two pillars, anterior and posterior fascial pillars. So these pillars develop from the second and third pharyngeal arches, because these are the muscles, so they develop from the arches. So this process also takes place in the 8th week of fetal life. Now medial surface of tonsil has different crypts, that is irregular surface, and it is covered by the mucosa. So these things develop from the endoderm. Mucosa develop from the endoderm. So because it is endodermal structure, so mucosa develop from the endoderm, and this process takes place between 3rd and 6th months of fetal life. Now capsule of the tonsil is very important because it is encapsulated structure. So this capsule during the fetal life in the 5th month of fetal life. Now important thing is that it is encapsulated lymphoid structure. So lymphoid tissue develop from the surrounding mesenchymal tissues, and in the center of this is the germinal center. Germinal center start working after birth. Similar to tonsils, there are subepithelial infiltration of the lymphocytes in the nasopharynx. These are called adenoids, and they developed at the 16 weeks of fetal life. They are non-encapsulated. So it is very important that tonsils are encapsulated and adenoids are non-encapsulated. So what are the functions of tonsils? As all lymphoid tissues are important for immunity, so these tonsils are important for immunity. So important immunological role of tonsils. They start working after 2 years and they reach maximum their size at 10 years. So this is the period of 8 to 10 years when they are immunological active. So active stage will cause hypertrophy of the lymphoid tissue, that is called hyperplasia. You can see in children tonsils are enlarged as compared to adults because of this immunological process that is active in children. So they become less important after 10 years of age, but they remain in the tonsillar fossa throughout the life. This is important because adenoids disappear in adults, but tonsils will remain in the tonsillar fossa throughout the life. Now why it is important? Because carcinoma of the tonsils can develop. If tonsils are present in the tonsillar fossa, carcinoma can develop inside the tonsils. So important thing is that they have no afferent lymphatics. No structure will drain into the tonsils, but tonsils itself drain into the cervical, upper cervical lymph nodes. Important lymph node is jugulo-digastric lymph node. You can see jugulo-digastric lymph node is the part of upper cervical lymph node that is present at the angle of mandible and sternocleidomastoid. So whenever there is infection of the tonsils, this lymph node will get enlarged. So important thing is to palpate the jugulo-digastric lymph node along with the tonsillar infections. So important things that is usually asked in Viva: what are the differences between adenoids and the tonsils? So I have told you adenoids are the lymphoid tissues that is present in the nasopharynx, and tonsils are the lymphoid tissue that is present in the lateral wall of oropharynx. So first difference is capsule. Adenoid has no capsule, tonsil has capsule. Adenoids are present in the postero-superior wall of nasopharynx. Tonsils are present in the lateral wall of oropharynx. Adenoids are midline structures. Tonsils are 2 in number and present on each side of oropharynx. Now epithelium. Adenoids are covered by the epithelium of nose and nasopharynx, that is ciliated columnar epithelium. Tonsils are covered by epithelium of the oral cavity and oropharynx, that is stratified squamous epithelium. Adenoids are in folds. There are different folds that can enlarge anteriorly, that can enlarge laterally. Medial surface of tonsil is irregular. We call this medial surface, it has crypts. First crypt is a large crypt that is called crypta magna. Another important thing is that adenoid has both efferent and afferent lymphatics. Nose and paranasal sinuses drain into the adenoids, but tonsil has no efferent lymphatics. Nothing drain into the tonsils, but tonsil drain into the jugulo-digastric lymph nodes, and adenoids drain into the upper cervical lymph nodes. Then age difference. Before 2 years of age, there is no enlargement of the adenoids. Although this structure is present in the nasopharynx, but if a child presenting with nasal obstruction, bilateral nasal obstruction or unilateral nasal obstruction, it is not due to adenoid, because they start growing after the age of 2 years. It is very rare they get enlarged before 2 years, but usually they enlarge after the age of 2 years. Then they will reach their maximum size by the age of 5 years. Then they start shrinking after that, and in teenagers, adenoids will disappear. Teenagers will not have any adenoid tissue, and they completely disappear by the end of 20 years. Tonsils are immunologically active between 3 to 8 years. They regress but not completely disappear. Okay, so tonsils are present in adults, adenoids are not present in adults. So you can see in this picture, Adenoids are present in the postero-superior wall of the nasopharynx. This is nasal cavity, this is nasopharynx. And tonsils are present in the oropharynx. You can see in this picture, on both sides of oropharynx are the tonsils. So what is the anatomy of palatine tonsils? These are the aggregation of the lymphoid tissue present in the lateral wall of the oropharynx. So these are the parts of oropharynx located between anterior and posterior fascial pillars. You can see these are the anterior fascial pillar and this is the posterior fascial pillar. These are the part of the Valdier ring. So we will discuss Valdier ring in the next slide. So these are encapsulated, medial surface is covered by the different crypts. First crypt is important, that is called crypta magna, and it is large crypt, represent the ventral part of the second pharyngeal pouch. Crypts and medial surface is covered by the stratified squamous epithelium. So stratified squamous carcinoma is common in tonsils. They have no afferent lymphatics, and efferent lymphatics drain into the jugulo-digastric lymph nodes. So it is important. So what is Valdier ring? Pharynx is encircled by lymphoid tissues. They form outer ring and inner ring. Inner ring is called Valdier ring. In inner ring we include palatine tonsils laterally, anteriorly lingual tonsils, and tubal tonsils around the eustachian tube. These are laterally present in the nasopharynx and posteriorly are the adenoids. So these tonsils are the part of the Valdier ring. In outer ring we include submental lymph nodes, submandibular lymph nodes laterally, jugulo-digastric is the main upper deep cervical lymph nodes, and then the retropharyngeal lymph nodes. They form the outer ring. So inner ring is called Valdier ring. So what is tonsillar bed? This question is usually asked in Viva. What is tonsillar bed? So tonsil is present in the tonsillar fossa over the tonsillar bed. So structures that form the tonsillar bed are the capsule of the tonsils. Capsule of the tonsils is the condensation of the pharyngobasilar fascia. So outside the capsule is the peritonsillar space. You can see this is the peritonsillar space. In peritonsillar space there are the loose areolar tissues and the paratonsillar vein. You can see paratonsillar vein drain into the jugular vein. Then pharyngobasilar fascia. You can see pharyngobasilar fascia. Then superior constrictor muscle. Outside the superior constrictor muscle is the buccopharyngeal fascia, and superiorly, posteriorly there is also the styloglossus muscles. Styloglossus muscles and the glossopharyngeal nerves. All these structures form the bed of the tonsil. Then more laterally there is medial pterygoid muscles, then ramus of the mandible and parapharyngeal space. So all main vessels are present in the parapharyngeal space. What are these main vessels? These are common carotid, internal, external carotid artery and the internal jugular vein, and last 4 cranial nerves. Tonsil bed is important. Now we come to the blood supply of the tonsils. There are 5 main vessels that supply the tonsils. Main tonsillar artery is the branch of the facial artery. Facial artery also give another branch, that is ascending palatine artery. You can see this facial artery is giving 2 branches and one is the ascending palatine artery. So maxillary artery give descending palatine artery, and the ascending pharyngeal artery also gives some branch to the tonsil. Then one branch comes from the dorsal lingual artery. So these are the 5 main branches that supply the tonsil. Sometimes there is aberrant internal carotid artery just lateral to the superior constrictor muscles. So some branches can come from the internal carotid artery, but it is very rare, only in 1% of the cases. So it is very dangerous while doing tonsillectomy and there is evident internal carotid artery, so there might be some injury to the internal carotid artery, and during the surgery there will be intense bleeding from the internal carotid artery. Histology is the same as in other lymphoid structure. Capsule on the lateral surface and on the medial surface is the stratified squamous epithelium. Cross section will show extrafollicular zone, mental zone and the germinal center. Now we come to the common diseases of the tonsils. We divide into infections, tumors and miscellaneous conditions. So in infections, acute and chronic infections are common. Acute infections are acute catarrhal, acute follicular, acute membranous. So in chronic tonsillitis, we divide into non-specific and specific. Specific are tuberculosis and syphilis. Non-specific are, these are actually the recurrent acute attacks. If there is recurrent acute attacks, infection can involve the deeper tissue of the tonsil. So patient can present with recurrent acute attacks because antibiotics are not sufficient to kill the bacteria deep to the tonsillar structure. So if there is infection in the deeper tissue of the tonsil, it can present with recurrent infection, and we call this recurrent infection chronic tonsillitis. So this is non-specific infection, contain gram-positive, gram-negative bacteria as well as anaerobes. What kind of the tonsils will be? They can be hypertrophic or atrophic. Hypertrophic means they will be non-congested but hypertrophy. Their mass will be increased. Atrophic, because of scarring, recurrent infection, they can be atrophic and fibrotic. This is the chronic tonsillitis. So tumors, as it is lined by stratified squamous epithelium, so there may be squamous cell carcinoma, lymphoid tissue, so malignant tumor may be lymphoma. There is also salivary glands, so patient can present with benign tumor, that is pleomorphic adenoma. Miscellaneous conditions are foreign body in the tonsil, cyst in the tonsil and tonsillate. We will discuss this later. Acute tonsillitis, there is some predisposing factors: poor orodental hygiene, diminished resistance, child is not taking proper diet, sudden change in weather. Common cold is important and it can also cause infection in the tonsils. Oral and nasal infections such as rhinitis, sinusitis, and in children adenoiditis is very important. So important causative organisms, viruses are the most common pathogens. So which viruses are important? Adenovirus, rhinovirus, influenza virus. Epstein-Barr virus is very dangerous infection. It can cause infectious mononucleosis, and infectious mononucleosis can cause lymphoma. So important bacteria in throat infections, important infection is group A beta hemolytic streptococci, that is Streptococcus pyogenes. Other bacteria are Streptococcus pneumoniae. Then in chronic stage we can see anaerobic streptococci, H. influenzae, Moraxella catarrhalis and Staph aureus. Important thing to remember is that acute tonsillitis will cause infection of the superficial layers. If there is no recurrent infection and there is one attack of acute tonsillitis, it will cause infection of the superficial layers of the tonsils. So in acute tonsillitis can be treated medically. What are the clinical features? It contains symptoms and signs. What were the symptoms of the patient? General symptoms. In every acute condition, patient will present with fever, malaise, anorexia, headache, rigors, body aches. If patient is swallowing pus, then there will be abdominal pain called tummy tonsil, or sometimes there is vomiting because of ingestion of this pus. Patient can present with vomiting. Locally there will be pain in the throat, odynophagia, that is painful swallowing, halitosis, bad breath. Then because of pain in swallowing, that is odynophagia, there will be salivation. There will be increased salivary secretions in the mouth because patient cannot swallow, so he will spit this saliva. There may be earache. Why there is earache? Because of referred pain. Glossopharyngeal nerve supply the oropharynx, and there is referred pain due to this tympanic branch of glossopharyngeal nerve into the ear. So what are the signs? Signs are the things which you will pick on clinical examination. When you will examine the throat, you will see hypertrophic, enlarged, congested tonsil. Just you can see in this picture. So catarrhal congested are usually seen in viral infections or initial stage of bacterial infections. So sometimes there are microabscesses are formed and you will see yellow spots over the tonsils. That is called acute follicular tonsillitis. Then in later stage, these yellow spots coalesce and they form membrane over the tonsils. Just in this slide you can see formation of membrane over the tonsils. It is usually the slough over the tonsils. What is the differential diagnosis of the membrane over the tonsils? There are certain conditions that can cause infection of the tonsils, and later on there is formation of membrane over the tonsils. Important condition is diphtheria. Diphtheria is the infection that is caused by gram-positive Corynebacteria diphtheria, and this is the infection that will cause degeneration or necrosis of the superficial epithelium, and there is membrane formation over the tonsils in the oropharynx, nasopharynx and hypopharynx and larynx and trachea. So this is true membrane. Whenever you will try to separate this membrane from underlying structure, there will be bleeding. Then infectious mononucleosis is another condition that causes infection of the tonsils and pharynx. Red color spots are seen over the soft palate. Tonsils will be hypertrophic and there will be slough over the tonsil and bilateral cervical lymphadenopathy. When you will advise blood CP, there will be atypical cells in the blood pictures. Monospot and Paul Bunnell test will be positive. So Vincent angina is caused by spirochetes and bacteroids. So how will you diagnose Vincent angina? There is black necrotic membrane over the tonsil and spirochetes stain through silver nitrate solution. So patient will present with severe pain in the throat and poor orodental hygiene, agranulocytosis and acute leukemia. Some patients of these blood dyscrasias present with sore throat. There will be severe infection of the tonsils, but pain will be less as compared to acute tonsillitis. You will see severe infection of the tonsil and pain will be less, and along with this there will be other signs and symptoms of acute leukemia and agranulocytosis. Behçet disease is the condition in which there is uveitis, oral ulcers as well as genital ulcer. AIDS is immunocompromised disease. Patient will present with multiple infections along with tonsillitis. So how will you diagnose acute tonsillitis? Diagnosis depends on clinical features and investigations. To start with clinical pictures, patient will have muffled voice, that is hot potato voice. Something is present in the throat. There will be bad breath and taste. There will be refertoptalgia and all the signs of acute tonsillitis. There may be hypertrophic or congested tonsils. Jugulodigestic lymph nodes may be enlarged and this lymph node will be tender. Tonsil may be hyperemic, may be congested, may be acute follicular tonsillitis, yellow spots can be seen, or there may be membrane over the tonsils. Investigations, you will advise blood CP. Blood CP will show neutrophils, increased neutrophil count in blood pictures, and you can see, you can take culture sensitivity, and culture sensitivity show will the specific bacteria which is present, and usually it is beta hemolytic Streptococcus pyogenes. So how will you treat acute tonsillitis? Because it is infections treated by antibiotics. Broad spectrum antibiotics means you will advise antibiotics that will cover all these bacteria, because if single attack of acute tonsillitis, we can treat it without doing culture sensitivity test. So we will prescribe broad spectrum antibiotics. Fluid replacement, because patient may be dehydrated, so you will replace the fluid. IV fluid can also be given, and you can ask the patient for goggles. Saline goggles can be used for these conditions. So what are the complications of acute tonsillitis? If you are not treating acute tonsillitis, it can be converted into chronic form. Chronic means recurrent acute attacks. Go into the deeper tissue, and patient can harbor this infection, and recurrent infection whenever there is multiplication of this bacteria, so there will be recurrent infections, that is called recurrent acute tonsillitis. Or infection can go into the peritonsillar space causing peritonsillar abscess, can go into the retropharyngeal abscess because of involvement of retropharyngeal lymph nodes. Infection can go into the retropharyngeal space through this peritonsillar space infection. Then infection can also go into the parapharyngeal space causing parapharyngeal space infections. And then regional infection can involve the middle ear causing otitis media. Laryngitis can go into the larynx, bronchitis, and then gastroenteritis. Recurrent swallowing of this pus can lead to gastroenteritis. And then there will be cervical lymphadenitis. Cervical lymphadenitis infection can involve the lymph nodes with the jugulo-digastric lymph node. Systemic infections are important. This infection can act as focus of infection. And then there is specific things that are rheumatic fever and acute glomerulonephritis. Antibodies are formed against the patient's own tissues, causing rheumatic fever and glomerulonephritis. If infection going into the blood, it can cause septicemia. So all these are the complications of acute tonsillitis. So what is chronic tonsillitis? Chronic tonsillitis means acute recurrent infections involving the deeper tissues of the tonsils. Chronic tonsillitis is common in children. So what is the etiology? Etiology is the recurrent acute infections. Acute infection involves the superficial tissues. If you are not treating the acute tonsillitis, it can involve the deeper tissue, and bacteria will remain inside the deeper tissue and then can lead to recurrent acute attacks. Or if patient is having any problem in the nose and sinuses such as sinusitis, so post-nasal drip can cause recurrent tonsillitis. In children, adenoid infection is common. So adenoid will leading to mouth breathing, or adenoid leading to post-nasal drip can lead to chronic tonsillitis. So as I have told you, it involves the deeper tissue. So colonization of the bacteria, then bacteria will multiply, and then they will present with as acute tonsillitis, recurrent attacks of acute tonsillitis. Then if patient is not presenting in acute stages are acute catarrhal, follicular and membranous. If patient comes to you with history of recurrent acute attacks, but at this time there is no acute attack, so tonsils may be hypertrophic without congestion, or may be atrophic due to recurrent acute tonsillitis can cause fibrosis of the tonsils. So you can see these two forms. Hypertrophic forms without congestion, or atrophic forms. So these two forms are seen in chronic tonsillitis if patient is not presenting in acute phase. So bacteriology pathogens are mixed, usually Streptococcus, Staph aureus and Streptococcus pneumoniae, that is gram combination of gram positive and gram negative bacteria along with anaerobes. So what are the signs and symptoms of chronic tonsillitis? We will label the patient as chronic tonsillitis when patient is having 6 to 7 attack of acute tonsillitis in 1 year, or 4 to 5 attacks per year for the last 2 years, or 2 to 3 attacks per year for the last 3 years. If in history patient is having these types of attacks, so we will label it as chronic form. Patient will have thick voice because if tonsils are hypertrophic, there will be hot potato voice. Something is present in the throat, so it will be muffled voice. Bad breath and taste. Recurrent acute tonsillitis with referred-otalgia. There will be history of these recurrent attacks with otalgia. If patient is having hypertrophic tonsils, such as in this, called kissing tonsils, there will be difficulty in swallowing and difficulty in sleep. So there will be obstructive symptoms, snoring and dysphagia. Obstructive symptoms are called sleep apnea. If there is problem in sleep, cessation of breathing during sleep is called sleep apnea. So you will ask about obstructive symptoms of tonsillitis. When you will see the tonsils will be hypertrophic, jugulo-digastric lymph node will be enlarged but non-tender in chronic form. General symptoms, patient health will be not good. Their parents will complain that patient is not gaining weight. There may be recurrent GI troubles. Patient will have recurrent diarrhea and pain in abdomen. And it can also act as septic focus. There will be recurrent infection of joints, recurrent osteomyelitis and other infections in the body. So how will you say that patient is having recurrent acute attacks on clinical examination? This is very important. These questions is usually asked in your bio. On examination, tonsil may be unequal in size. There will be prominent crypts. Medial surface will be irregular, showing prominent crypts. There will be flaring of anterior fascial pillar, that is called peritonsillar erythema. It is because of thrombosis of vessels. There will be flaring, blushing of anterior fascial pillar. When you will press the anterior fascial pillar over the tonsil, pus will come out of the tonsil. So this is the very important signs, oozing of cheesy material from the crypts. Then persistent enlarged jugulo-digastric lymph node, that is non-tender. All these are the clinical signs you will pick on clinical examination. These questions really asked in your viva. How will you treat the chronic tonsillitis? How will you treat the recurrent acute attacks? We will advise tonsillectomy. So what are the absolute indications of tonsillectomy? Absolute indications, recurrent acute attacks, you will ask in the history. There will be 6 to 7 attacks per year. In 1 year, patient will have 6 to 7 attacks. There will be history of 4 to 5 attacks per year for the last 2 years, or 2 to 3 attacks per year for the last 3 years. Tonsils, hypertrophic tonsils causing obstructive symptoms such as sleep disturbances and swallowing problem, that is called dysphagia. Peritonsillar abscess, single attack of peritonsillar abscess. If patient is giving history of single attack of peritonsillar abscess, there may be second attack in some individuals. If patient comes to you with second attack of peritonsillar abscess, then it is the absolute indication of doing tonsillectomy. If tonsils are unequal in size, there may be chances of malignancy. So, if you are suspecting any malignancies, you will advise tonsillectomy. So, what are the relative indications? Relative indications means these are not the absolute indications. So, some surgeons can advise doing tonsillectomy, and some can. It depends on the patient decision. So, recurrent otitis media, recurrent respiratory tract infections, and recurrent sinusitis due to tonsillitis. So, you can advise tonsillectomy. Sometimes patient presenting with bad breath due to collection of debris in the crypts, so you can advise tonsillectomy. Some in diphtheria carrier, you can advise tonsillectomy. Some benign tumors of the tonsils such as papilloma, fibroma, in these tonsillectomy can also be done. And as a part of another operations, if there is elongated styloid process causing glossopharyngeal neuralgia, you can approach it through tonsillar fossa after removing the tonsil. Second arch anomaly, there is branchial cyst. Inner opening is in the tonsillar fossa, so you can remove this after removing the tonsils. Then, as a part of snoring procedures, that is uvulopalatopharyngoplasty, tonsil lath. Tonsil lath is the collection of debris in the tonsillar crypts, and then there is deposition of the salts over this debris, causing a hard mass is present in the tonsillar crypt, and it will cause constant irritation in the throat of the patient. So you can advise tonsillectomy. Sometimes cyst, some salivary glands, ducts are injured or get obstructed, so there is formation of cyst. You can advise tonsillectomy in these patients. Impacted foreign body, sometimes foreign body get impacted inside the tonsils, and it is very difficult to remove this, so you will remove whole tonsils because of this impacted foreign body, because it can act as focus of infection. In cases of rheumatic fever and acute glomerulonephritis, beta hemolytic streptococcus pyogenes can act as septic focus. So, we will remove the tonsil in these patients. So, what are the contraindications? Absolute contraindication is decrease hemoglobin. If hemoglobin is less than 10 gram, we will not advise tonsillectomy. We will improve the hemoglobin level, then we will perform tonsillectomy. If patient is presenting with acute infections, we will avoid tonsillectomy because of chances of septicemia. Because they are active in children, immunologically active in children, so we will not do tonsillectomy before the age of 3 years. It is important to remember that immunologically tonsils are important, but if they have become the focus of infection, if present of infection in the deep layer of the tonsils, we will have to remove these tonsils to prevent recurrent infections. In cases of submucous palate, bone is absent and the palate is only covered by the mucosa and the muscles. So, in cases of submucous palate, we will avoid doing tonsillectomy because there will be more chances of rhinolalia aperta and the speech will be disturbed in this patient. So, we will avoid doing tonsillectomy. Bleeding disorders, if patient is having any blood dyscrasias, leukemia or platelet deficiency, aplastic anemia and hemophilia, we will avoid tonsillectomy. At the time of epidemic polio, because after doing tonsillectomy, the nerve endings are exposed, so polio virus can penetrate through these nerves, causing bulbar polio. If patient is having any systemic disease such as diabetes, cardiac disease, hypertension or asthma, this is the relative contraindications. So absolute contraindications is hemoglobin less than 10 gram per percent, but you will have to improve hemoglobin before doing tonsillectomy. And in blood dyscrasias, if there is chances of bleeding, so you will avoid doing tonsillectomy. So what are the different procedures of doing tonsillectomy? First of all, we will discuss pre-operative preparation. How will you prepare your patient? You will take proper history, you will rule out any nasal pathology, you will do complete general physical examination to discover any disease, and you will do local ENT examination to rule out adenoid hypertrophy, turbinate hypertrophy, DNS. Then blood investigations that are required are hemoglobin level, you will see WBC's level, and you will see platelet level. Then you will advise prothrombin time and activated partial prothrombin time to rule out any bleeding disorder. Then blood sugar level and hepatitis profile is also done. And then you can advise urine examination for sugar and albumin to rule out any disease. Operative preparation is in the operation theatre. Patient lies on the operating table and it is done in general anesthesia. Oral and nasal intubation can be done. We will pack the throat and we will prevent any trickling of secretions inside the larynx, because larynx can go into the spasm because of these blood clots, or there will be aspiration pneumonia. So patient will be in supine position, neck is extended, patient is draped, all the exposed area is cleaned with the help of iodine. Surgeon will stand on the head side of the table. So tonsillectomy techniques, there are different techniques. Easy method is dissection method. Then we can use electrocautery, carbon dioxide laser or other lasers. Coblation method, cryosurgery, harmonic scalpel, radiofrequency ablation and micro debrider. So we will discuss each procedure one by one. Dissection method is the easy method. It is done by cold knife. Knife means it is done by the dissector. And dissection is done in the peritonsillar space. We dissect the tonsil outside the capsule of the tonsil in the loose areolar tissue. We start dissection at the upper pole because near the upper pole loose areolar tissues are maximum. So we will give incision, we will approach the peritonsillar space and we will dissect the peritonsillar areolar tissue. We will make a dissection between capsule and superior constrictor muscle in the loose areolar tissue. We will cut this loose areolar tissue and then we will reach the lower pole. We will reach the lower pole and we will make a pedicle near the lower pole. This pedicle is tight or cauterized, tied with the help of ligature or cauterized. Bleeding is controlled initially by pressure, by putting gauze in the tonsillar fossa, and these bleeders can be ligated and can be cauterized. So this is primary hemorrhage, is the hemorrhage during the procedure. So there are three methods: pressure method, ligation method and cautery method. You will cauterize the bleeders. What are the disadvantages of this method? There will be more bleeding because we are dissecting the tissues, so bleeding will be more. There will be more pain after operation, post-op pain will be more, but it is cheap and easily available in all the centers, and we don't require any special or specific equipment. So you can see these are the instruments that are usually used in dissection methods. This is Boyle-Davis mouth gag. In this is Boyle-Davis mouth gag, tonsil holding forceps, Negus forceps, straight artery forceps. This is dissector and pillar retractor. This is adenoid curette, because we often do adenoidectomy along with tonsillectomy. Patient is having hypertrophic adenoids. These are the suspending rods, and this is the forceps for cautery. That is, if you are using bipolar cautery, this is for this. This is stitch ligature. Okay, these are different blades. We use these blades in this gag. So Boyle-Davis mouth gag. So what is electrocautery method? We can use monopolar cautery and bipolar cautery. You can see this is monopolar cautery and this is bipolar cautery. We cauterize the tissues outside the capsule in the loose areolar tissue, and this cautery has cutting end and coagulating end. Bleeders are cut and cauterized. This is easily available in all centers. Bleeding is very less, but post-operative pain is more, and because of lot of slough is formed after using cautery, so there are more chances of secondary hemorrhage in these cases. Harmonic scalpel is not easily available, but most of the centers now have this scalpel. They use ultrasonic energy and vibrate the tissues, and they vibrate the tissue, they cut and coagulate. It is called ligature. So tonsillectomy ligature is used. You can see in this picture, you can see that they cut and cauterize. Okay, so this can be used in different types of surgeries. In thyroid surgery, we also use this instrument. So it is easy, but it is expensive, because we have to buy this forceps in each patient, but bleeding is less and recovery is early, and now it is gaining popularity and different centers have this ligature. So carbon dioxide laser and diode laser and KTP lasers, these are used for doing tonsillectomy. What is laser? Laser is the light amplification of stimulated emission of electromagnetic radiation. Very expensive technique. Most of the centers don't have this technique, but it is very useful. Early recovery, less bleeding, less pain in the patients. We should take specific precautions while doing lasers. Eye protection, specific tube should be used, and because it can cause trauma to the surrounding structures, so you have to protect all other structures. It vaporizes the tissues. So if you are doing tonsillectomy for taking histopathology, you cannot use this technique because it vaporizes the tonsils. Coblation method is very new method, and very few centers have this technique. In this technique, we use bipolar radiofrequency at very low temperature. So thermal damage will be less. It creates an ionized saline layer that weakens the molecular bonds between the tissues. So it will cut the tissue and coagulate the tissue. Post-operative pain is less, and bleeding is, during operation, bleeding is less. It is costly and not easily available. Then radiofrequency ablation. In this technique, we use monopolar radiofrequency at very low temperature. Okay, so it can also be done in OPD, because these are the simple probes. It is done intracapsularly. We will inject this probe inside the tonsil and then we will use this technique. It will cause thermal ablation of the tonsil tissue. It will regress the tissues. It will cause fibrosis of the tissue. So it will reduce the size of the tonsil. So this technique is usually done in cases whenever patient is presenting with obstructive symptoms, that is dysphagia and sleep apnea. It is not suitable for chronic infections and usually it is not available in every center. It can be done as OPD procedures, minimal discomfort to the patient. Microdebrider, all the centers that have facility of doing endoscopic sinus surgery have this instrument. This is microdebrider. It shaves the tonsil. Bleeding is more, but less time is required of doing tonsillectomy. Later on, bleeders are caught with the help of cautery. So now we come to the complication. Any procedures that is done under general anesthesia, there will be complications of anesthesia, then specific complications of surgery. So general complications of anesthesias are aspiration during recovery. If patient is nothing by mouth, so patient can vomit and these vomiters can go inside the lungs causing aspiration. There may be pulmonary edema, there may be bronchitis, pneumonia, abscess, bronchiectasis and atelectasis. All these are the complications of anesthesia. Now complications of surgery. So specific complication of tonsillectomy, the most important complication is hemorrhage. We divide the hemorrhage into primary and secondary hemorrhage. Primary hemorrhage, that is at the time of operation and at the time of recovery, that is reactionary hemorrhage. It occurs within the 24 hours. So we divide the primary hemorrhage into hemorrhage during the surgery and reactionary hemorrhage within 24 hours. So reason, one is surgery, other is when patient recovers, so their blood pressure will increase and sometimes there is slippage of ligature. The points which were not bleeding at the time of operation, when blood pressure rises, they start bleeding. So this is the reactionary hemorrhage. Secondary hemorrhage is the hemorrhage that is due to infection and it will occur after 24 hours. Usually it will take 3 to 7 days. This complication is rare, but incidence is 2 to 3% in each operation. So how will you control primary hemorrhage? Primary hemorrhage is controlled by giving pressure with the help of gauze, then ligation with the help of stitch and cauterization of bleeders with the help of unipolar and bipolar cautery. Reactionary hemorrhage that occurs in the ward after the operation, patient will present bleeding through mouth within 24 hours. So what will you do? You will save the IV line, you will put adrenaline soaked gauze in the tonsillar fossa, then you will prepare the patient for general anesthesia. You will pass the NG tube. If there is swallowed blood or patient has taken anything, you will pass the NG tube to prevent vomiting during second anesthesia. If you have failed to control the bleeding through this adrenaline soaked pack, then you will shift the patient to the operation theatre. And second anesthesia is given. There are different problems with the second anesthesia. So After anesthesia, these points, these bleeders were ligated or cauterized. So secondary hemorrhage, what is secondary hemorrhage? That is due to infection. Patient will come to you after 24 hours. Usually takes 3 to 7 days to develop the infection. So patient will present with mouth bleeding in emergency with fever, and there will be history of tonsillectomy. When you will see the tonsils, there will be blood clot. So clot in the fossa is very dangerous. You will have to remove this clot. In every type of hemorrhage, you will have to remove this clot because it will prevent the contraction of the vessel. So if there is clot inside the tonsillar fossa, in primary hemorrhage, secondary hemorrhage, you will remove this clot. How will you treat the secondary hemorrhage? You will give, first of all, you will give conservative management. You will admit the patient. You will send blood for cross match. You will arrange 1 pint, at least 1 pint of blood, and you will give antibiotic to the patients. You can keep adrenaline soaked gauze inside the tonsillar fossa. In all type of hemorrhages, if you have failed to control the bleeding, ultimate treatment is ligation of external carotid artery. Because in cases of secondary infection, it is very difficult to cauterize and ligate the tissue. So we can put some coagulative material inside the tonsillar fossa. You can do pillar to pillar stitching. If you have failed to control the bleeding, then ultimate result will be ligation of external carotid artery to save the life of the patient. So other complications are post-operative pain, post-operative otalgia, that is referred pain, dehydration if patient is not taking proper diet, is not swallowing anything, so there will be dehydration, fever due to infection, post-operative airway obstruction. Sometimes if damage to the surrounding structures, there will be edema of the uvula. Patient can present with airway obstruction. Sometimes hematoma or blood goes into the larynx. Patient can present with laryngeal spasm. So it is very dangerous. You have to pack the throat and you have to do clean surgery. And before sending the patient to the ward from recovery, you have to be satisfied that there is no bleeding from the tonsil. If your surgeon is destroying the surrounding tissue, there will be some edema of the surrounding tissues leading to more pain. Sometimes tonsillar remnants remain, so hypertrophic of these remnants. This is very rare if you are not doing tonsillectomy properly. So there will be regrowth of these remnants and patient can have recurrent acute tonsillitis. So in the end we will discuss the scenarios. First scenario is that a 7-year-old boy presented in emergency with fever and bleeding from mouth. There is history of tonsillectomy 5 days back. Throat examination revealed clot in right tonsillar fossa. What is your diagnosis and how will you manage the case? So diagnosis is very easy. It is case of secondary hemorrhage after tonsillectomy. So how will you manage the case? You will admit the patient. You will check blood pressure and pulse of the patient. You will send blood for cross match. You will save the IV line of the patient. and because secondary hemorrhage is due to infection, so you will give proper antibiotics, intravenous antibiotic to the patient, and then you will remove the clot and you will pack the tonsillar fossa with gauze soaked in adrenaline. And if you fail to control the bleeding, then you can shift the patient to operation theatre and you can put some coagulative material such as Spongiostan and other thing inside the tonsillar fossa, and you can do pillar to pillar stitching if there is still bleeding. And you will give in IV fluid, and also the blood you will transfuse the blood to the patient. If there is still bleeding, then you will think of ligation of external carotid artery. Now we come to our previous scenario. Ahmed, 24 years of age, came to ENT OPD with history of right earache for last 2 days. He had high-grade fever and also severe rhodinophagia. Throat examination revealed hypertrophic congested tonsils with yellow spots over the surface. He is giving history of similar attacks since childhood. What is your most probable diagnosis? What otoscopic findings you are expecting? Give management plan. So diagnosis is again very easy. Case of acute follicular tonsillitis. As there is rapid pain in the ear, so tympanic membrane will be normal. And what is management? Management is that if patient condition is not very critical, so you will give antibiotic to the patient, you will give antipyretic, you will give painkiller, and you will ask for goggles, saline goggles. Then you will take care of hydration of the patient. If patient is dehydrated, then you can give IV fluid and you can ask to take care of proper diet of the patient. So all this is the management plan. Thank you for your patient listening, and if you like this lecture, then give your feedback and subscribe this channel. Inshallah, we will continue with more lecture, and these lectures are for undergrads, and we will cover inshallah all the topics related to your syllabus. Thank you very much.